Good afternoon. I'm Carrie Remmel, Director of Stroke here, and I'm happy to give you a 1-hour lecture on emergency stroke. Do you know that there is a fellowship for internal medicine in stroke? So we don't have it here, but a friend of mine in Tulsa, Oklahoma, who has a comprehensive stroke center by Joint Commission, also has a couple of internal medicine people who've been early stroke specialists, and so they do very well and have a good time taking care of patients with stroke. Wherever you go, whatever hospital you're working in, of course you're going to be getting involved in patients' care with stroke. So it is important that we talk about it. I think it's also important to talk about stroke and TIA, how they are related. Are they the same thing? Are they different? We'll talk about the aspects like rapid assessment in the emergency department, mentioning the NIH stroke scale that's used very widely and respected and quick. Also, IVTPA, which is the only FDA-approved drug for stroke care still, was approved in 1996, and it's still the only FDA-approved drug. Talk about the endovascular treatments that we have available that are being used regularly but are still investigational. And then we'll talk about what happens with emergency stroke in patients that aren't intervention or TPA candidates. We're not going to talk about stroke risk factors or etiologies or prevention guidelines. There are some current or new guidelines out, and we change our stroke protocols based on the updated guidelines. This is the only comprehensive stroke center in Kentucky, the first. There will be more. There probably are going to be 150 to 200 in the country. We were the 20th, and we're very proud of that. It takes a lot of work from the nurses and the administrators and the intensivists and neurosurgery. So many people are involved in this to make it work, and we're really excited about the work that's being done. In the emergency department of a stroke center, the ED is trained to see patients, diagnose them, and treat them acutely. So the ED personnel, nurses and doctors, are trained to do this. They also routinely are expected to communicate with EMS. As EMS is on their way in with a possible stroke, call ahead, and then the ER staff will call the stroke team ahead of the patient coming in. They prepare for the arrival of that patient. In this hospital, it's room 9, but whatever rapid assessment room that a hospital has, they get prepared for it, call the team in so that everybody can be ready. They use written protocols. This is Joint Commission requirement, written protocols for the acute care of stroke patients, because it increases efficiency, it reduces time and variability. So that's the problem. When you practice in other places, non-stroke centers and stroke centers, you're going to see a big difference. You'll see that there's quite a bit of variability in care of stroke patients, even now in hospitals that aren't stroke centers. You would expect that to be reduced, but it's not. So the stroke center concept by Joint Commission is, the goal is to have consistency and efficiency, because time really does matter. So the first question when the patient hits the door in the emergency department is it a stroke? Even though they may have a call ahead of time saying, I think I've got a stroke coming in, that's the first question that we have to ask. Is it a stroke? Because there are mimics. There are many mimics. And so a person can have a complex migraine. Certainly that's not high on our list. We're going to first think of stroke, but they could have extremes in metabolics. They could have extremely high or low blood sugars. They could have other metabolic problems. Even hypothyroidism can present with a focal deficit, a sudden focal deficit. So that's something to consider, but you're going to work them up when they come in with a sudden onset of a focal neurological change. I'm going to think about stroke first and work them up. Focal seizure. Sometimes these hospitals will call me and I'll beam in by telemedicine and look at a patient. They say, I'm getting ready to spike the drug and give IV TPA, and I beam in and I'm seeing a patient seizing. So that's, not a stroke, or maybe there's a stroke plus a seizure. Tumors, a patient will be flown in from an outside hospital for stroke because a CAT scan at the other hospital shows a hypodensity. And we get them here and we look at the patient, we get the history, we look at the scan, and we see what looks like a hypodensity but more specific for, or more consistent with a tumor, where there's a different characteristic when you look at the CTs, even if it's not a contrasted CT. We look at vasogenic versus cytotoxic edema. CNS infections can present as mimics, or there also can be vasculitis and can lead to strokes. And then, of course, intoxication. So on arrival in the ED, the critical points that we always tell people, we need to know the time of onset. But we've changed the wording now. We don't say time of onset because so many mistakes are made if you say what was the time of onset. Mistakes are made unless we say, when was the patient last seen normal? Oh, well, the last time he was at baseline or normal was when he went to bed, woke up with the symptoms. There's this whole literature now, I don't know if you've been reading about it, wake-up strokes. Many people wake up with their stroke. And then you think, well, there's nothing I can do for this person. But I will tell you a little bit more later about, yes, there are things we can do for them. But the time frame matters because the only FDA-approved treatment, IV TPA, is given in a specific time frame from what we believe is the onset time or last seen normal. We also need to know, did they have a prior stroke, and if so, when? Because one of the exclusions for IV thrombolytic is a stroke within the last 3 months. Why? Because those people tend to bleed. They will bleed with IV TPA. And residuals. What were their residuals? Oh, well, the person presents with right-sided weakness and aphasia. Yes, he had a stroke 6 months ago, and he still has residual right-sided weakness and aphasia, but we called 911 because it was worse. So is it really a new stroke, or is this a worsening of the old stroke? Is there something else going on with that patient? What else could be going on with that patient? Well, they get worse if there's a medical illness like an MI, like an infection, UTI. What if the person had a cortical stroke and they had a partial seizure, complex partial seizure, with no convulsion in the plegic side, but they had a worsening of their symptoms. So you really want to know when that stroke was and what the residuals were. And then also, what are their home medications? Are they on anticoagulation? Warfarin or one of the newer anticoagulants? Are they on antiplatelets? What are the other medicines? On arrival, of course, we're going to do all the usuals. We're going to check vital signs, IV access. A CT of the head is done very quickly, and in fact, by Joint Commission standards, you are expected in a stroke center, just a primary stroke center, you have to prove that you have been able to get those CAT scans of the brain within 25 minutes of the patient hitting the door. And we do pretty well here. CTA of the head and neck. That is not a requirement for IV TPA, please believe me, but in stroke centers, typically what you'll get is a CT-CTA. It's just an extra few minutes, and we can look at the vessels from the arch up. Why is it important acutely? Because I'll show you with some pictures, but that's going to give us information about, number one, what we're going to do with that patient. Even if we don't give IV TPA or some endovascular treatment, what are we going to do with them? Let's say I've got somebody and I'm looking at them and they have no carotids on either side. Oh my God. It happens. So we're kind of looking at the posterior circulation to see if they have collateral flow. But anyway, what I'm saying to you is we want to know what we're going to do with that patient when they come in. We need to know what the vessels look like. Stroke is a vascular event. That's why I showed that picture on the very first page of the vessels of the brain, because it is a vascular event. How many times do I get a patient that comes into my clinic as a second opinion from a neurologist or from someone else in the region, and they think that they've had this massive workup. You've heard them. Had a major everything, they checked everything. Oh, except for the vessels. They had a stroke, but nobody looked at the vessels other than a carotid ultrasound, which is not the initial study and not in the guidelines. It's out of the guidelines as an initial study. So yeah, we do CTAs of the head and neck or MRAs. There are times when you cannot get those and you need to get the carotid ultrasound or a TCD. We do the labs, tox screen on everyone. And the labs have to be drawn and back, resulted within 45 minutes of the patient hitting the door. We keep all of these times and Joint Commission reviews every time we have. So we are very, very specific about this. In fact, when a patient comes to this ER and is seen and is considered for TPA, we check every single aspect of the time frame, door to doctor, door to ED doctor, door to stroke team, door to CT, door to labs, door to TPA. And we look at that and we give back on the next working day, the next weekday, to all of the people involved, the ER resident, the ER attending, the stroke attending, stroke resident, the nurses, everybody, the lab, everybody gets feedback so that we can always continuously improve. I want to say something about the tox screen. So the oldest person that I had a positive cocaine on in this hospital was 83, a gentleman that had been using marijuana since the 70s. He said he started when his daughter got him started, and he used marijuana every day. This guy that still works, but he had just started using cocaine. Had a stroke. Cocaine can cause a vasculitis. It can cause vasoconstriction, as you know. So he did very well. So I'm in clinic after and talked about those drugs, and he said he quit the cocaine. He believed that it caused vasoconstriction. He believed that it caused a stroke. Asked about marijuana. He said he did not quit marijuana. He thought that it was a vasodilator because his eyes were bloodshot after he used it, and he thought that that would be okay. It's not okay, though. There's some new literature coming out related to stroke. Not definitive yet, though. So you don't give any antithrombotics of any kind acutely with a stroke. I have patients that come in and say, thought I was having a stroke, so I took 3 aspirin. What if it was a bleed? You don't know when a person presents with a sudden focal deficit, whether it's ischemic or a bleed. But we don't give them that. We don't give it to them in the ER. We don't want to give anything by mouth anyway until they have a swallowing evaluation. But we don't give antithrombotics, especially in the case where we might be giving TPA. 12-lead EKG, X-ray, chest X-ray, and we don't give D5W, just normal saline. NIH stroke scale, how many of you are familiar with NIH stroke scale? It's a standard. We use it in all of the clinical trials, and we get one on admission and discharge from this hospital, and again, outpatient. The NIH stroke scale, you have to be certified annually. There's an outside agency allowing for certification. And it looks at level of consciousness, looks at visual fields and gaze palsies or extraocular movements, looks at facial weakness or strength, and then arm and leg strength, sensory functions. It looks for dysmetria or ataxia. It looks at language functions, also speech, that is motor speech like dysarthria, and extinction, so sensory extinction, visual extinction. So that's, and it's very quick. So you can get very nice standard scale quickly. This just shows you, this comes from the Boston Aphasia Diagnostic Battery. These aspects, they're just portions of that aphasia battery, and you can get people, these are famous pictures that, you know, there are actually 60 in the Boston naming test, but they chose these. And so these are used in standard. That's just part of the test. We do that acutely because when I call, when the resident calls me from room 9 and tells me about the patient, I'm going to, my resident, I'll ask what the NIH stroke scale score is. I want to know. And what are the deficits. Now, acutely, this is acute ischemic stroke, CAT scan. Does it show any hemorrhage? No. And a TIA patient, CAT scan would be the same, acutely. Acutely with a stroke, ischemic stroke, you're not going to see the ischemia. Not going to see it. So there's not going to be a hypodensity acutely. How many times have you heard of a patient that goes to an outside hospital, goes to a hospital, and with deficits, focal deficits, sudden in onset, and they're discharged from the ER because their CAT scan was normal? The family will tell me, still had a facial droop and slurred speech, still couldn't hold things in the right hand, but we were discharged home because that CAT scan was negative. It takes hours for a CAT scan to show ischemia. So we're not going to make those mistakes, I hope. After 3 days, there's your hypodensity in a patient that had a left MCA occlusion. TIA and stroke are really the same condition and should be aggressively treated, aggressively worked up, the same. Just because a person had a 20 or 30 or 40-minute spell of a focal neurological deficit and then they're back to normal does not mean that they shouldn't get the exact workup as a person with a stroke, right? That's critical. There's a new definition for TIA. We no longer say that it's a stroke-like event that lasts less than 24 hours. The new definition is it's a stroke-like event that resolves usually within an hour and there is no infarct. About half of the patients that have a clinical TIA that lasts longer than 30 minutes actually have a stroke on MRI. And so we've changed the definition because we want people to be aggressive and we want them to think about TIA as an emergency. We certainly don't wait for the TIA, for the clinical symptoms to clear before we consider treatments either. We did a study here at U of L and looked at about 450 TIA patients compared to about 1,400 acute ischemic stroke patients. And really, their abnormalities on their workup, including TEE and lab workup and so forth, were the same. They're the same condition. You have to work them up aggressively. There's something called the ABCD2 score, which is supposedly going to guide you as to whether you should work that TIA patient up outpatient or keep them in the hospital. You're talking to someone who wanted this to be true. I wanted to have a TIA clinic on the outpatient side. So I did a study that looked at the possibility of doing this. And in the patients that had low risk scores, low risk, meaning discharge them from your ER, work them up outpatient, low risk. In this house, 15% of those patients' TEEs showed what Dr. Stoddard would say was serious cardiogenic sources, mobile thrombi in the arch, massive PFOs, low ejection fraction with spontaneous echo contrast. Anyway, so we, the 4 stroke neurologists here, have decided that we are not going to discharge TIA patients from this hospital. We are going to work them up. We usually can get everything done within 24 hours and they're out of the door if everything's fine. but it does change the management. It does, and there is a risk for stroke. So we don't use the ABCD2 score, except talk about it and consider it in research, but we don't use it here at the University of Louisville Hospital. The big deal here in therapy for stroke is saving the penumbra. I mean, I'm not going to be able to do anything about the core stroke, but usually in the acute setting, there's a penumbra, salvageable tissue. So that's really what we're going after. In all of the treatments, we're going after the penumbra. Is there a mismatch? So on MRI, we have diffusion-weighted imaging, you've all seen it, lights up for ischemic stroke, and perfusion deficit. And so there can be a diffusion-perfusion mismatch. And that area that is the mismatch is your penumbra, or salvageable tissue. That's the tissue we're going after. And what do we have available? We have IV TPA, 0 to 3 hours. We also, and that's the FDA, 3-hour window to get that drug in the person, or at least get the infusion started. 3 to 4.5 hour window that is not FDA approved, but is in the stroke guidelines, the current stroke guidelines as of 2013. And our group at first said we'll consider it, but we're not putting it in the for sure protocol. And then after we experienced it for a while, we put it in the protocol here at U of L. And then endovascular recanalization. So I don't think that we're going to go through every detail of the inclusion-exclusion criteria here, but they are on the slides and you should be familiar with them. I will highlight several, though. The exclusionary criteria are long. I'll highlight some. Now, age greater than 18, well, 18 or older, we've given it here 15 and 17-year-olds. So there are times when you are going to push the envelope to try to save brain, and that is done around the country. Stroke symptom onset less than 3 hours, clinical diagnosis that looks like a stroke. Of course, your CAT scan can't show this, any evidence for either intracerebral hemorrhage or subarachnoid hemorrhage. And, you know, you can see some of these others. The one that I want to point out on this slide, one of them is clearing spontaneously. Have you heard this one? Rapidly improving. Let me tell you how many times I used to hear it. When I'm on call, I get calls all night long from hospitals around the state, and they'll say, I really don't think I need to give it because the symptoms are rapidly improving. However, then when you delve into it, you say, tell me about the NIH stroke scale. Well, we don't know how to do that. Okay, tell me about the exam. Came in, was mute, plegic, facial droop, eyes deviated to the left, and now the patient is mumbling and can sort of lift against gravity. Well, you know, if everything else fits the criteria, you're going to get it. That's a measurable deficit. So you have to say improving to what? If it's improving to an NIH of 1 or 2 and it's really minor, like a sensory type of problem, then they're probably okay. But any cortical sign trumps it. I mean, if they have a 1 or 2 and it's aphasia, that's critical, and that trumps the number. And you really have to look at the individual patient. We individualize this care, but we tend to, we want to avoid using excuses not to give. Look at all of these exclusionary criteria. I'll point out a couple. So if the person's blood pressure is greater than 185 over 110, the original, if you are one of those kind of people that wants to read the original NINDS trial, and we've changed things. So in the original, they said you cannot treat blood pressure aggressively. Now, every stroke center in the country puts the person on a cardine drip or a nicardipine drip or gives them labetalol. And so we try to get the pressure down below 185 over 110. But if you can't, then you can't give IV TPA. of course, you're looking at a CTA to see if there are other alternatives for that patient. But in the meantime, the blood pressure is critical because there's a big mark where there's a larger hemorrhagic transformation or hemorrhage with TPA in the high blood pressure ranges. The other I wanted to point out was the INR. So in the 0 to 3 hour window, you can give IV TPA to a person on warfarin as long as their INR is not greater than 1.7. So just remember that. However, if they're on any of the newer anticoagulants, you can't give it. If they're on it, you're not checking levels, so you can't give it. In the NINDS trial, for a person to have minimal or no disability after their stroke, after getting IV TPA, there's a 32% relative benefit compared to placebo. Symptomatic hemorrhage rate across studies is around 6 to 7%. Symptomatic hemorrhage rate with TPA. The mortality is not significantly different between placebo and IV TPA. And then the benefit for function is improved no matter what the type of stroke. Even a small vessel stroke improves compared to placebo with TPA. You might have seen this before. This just tells you the sooner you give drug, the better. So the outcomes are on the y-axis. So outcomes are better early on, but as you come out, your outcomes, your functional outcomes for that patient decline. And just remember that time is not on our side when it comes to stroke. We've got to be quick, because for every 1 minute of ischemia, you lose 1.9 million neurons, 14 billion synapses. So I don't want to lose any. I don't know about you, but I don't have any minutes to spare. So I've had many people say, gosh, this person came in within 30 minutes. Let me go ahead and get an MRI because I don't really, let's see how bad it is. Well, we don't want to waste time. Let me get an MRI before we do TPA, give TPA. If they fit the criteria and they have a measurable deficit, then they should be allowed to have IV TPA. And as quickly as possible. There's even a term. Have you heard it? Drip and ship. CMS is using it. Drip and ship. So there's a higher DRG if I give TPA in this hospital compared to just a non-TPA patient with stroke. If an outside hospital gives the TPA, that's drip, and then ships it to a stroke center, so that's drip and ship. Neither one get the higher level DRG. But anyway, neither hospital. But my point is you don't ship and then drip. Why? Because of the loss of neurons on the way. Don't ever do that. But does it matter if we recanalize the vessel if we don't have improved function? So at 12 months after stroke, there was a significant difference between drug and placebo. The red line is improved, is improvement. So on the Barthel, you can see a big difference. Barthel, you're familiar with it. It's activities of daily living. Can you feed yourself? Can you take care of yourself? So Barthel index is significantly improved at a year out after stroke for those that get TPA. Modified Rankin is what we use extensively in stroke studies, and all of our patients get these on admission and discharge. But modified Rankin is significantly better than placebo if drug is better than placebo, and then Glasgow outcome score. Meta-analysis of 52 studies of thrombolysis with acute ischemic stroke shows about a 4-fold reduction in mortality and 4-fold increased chance of independence with treatment. What about that extended time window? See, before we had an extended time window, 3 to 4% of stroke patients got TPA, IV TPA. 3 to 4. We give it 20%. Our transfers, we're on the phone or on telemedicine 21% IV TPA, 21% of our transfers. 17 to 18% of the ones that show up here. So it's really hard to get them to come in on time. So we need something that will allow us to expand the time window so we can treat more people. So this was a study changing the criteria and seeing if we could have benefit outweighing risk, and we did. So it's not FDA approved, but it is in the current guidelines. The only difference is that in addition to all of the exclusions before, they can't be over 80. They can't be on any anticoagulation. Doesn't matter what the INR is on warfarin. They can't have a combination of a prior stroke plus diabetes. Doesn't matter when the stroke was. And they can't have a severe stroke where that would be somebody who's obtunded, really. And then just to let you know, you need, in a stroke center, you really need to be able to give the drug within an hour of the patient hitting the door. So you have to have all these pieces and parts in place, everything lined up, labs, all the decision making can be done within an hour, and you'll see better outcomes if that is done. So there's a dose of 0.9 milligrams per kilogram. We give 10% as a bolus, and we drip the rest in over an hour. The highest dose is 90 milligrams. And then we have to document, document, document. Patients go to the ICU at least for 24 hours. There are protocols. I'm not going to read this to you. There are protocols available. They're on e-forms, but we have orders and protocols for all of these things so that we meet all of the important guidelines. Every single aspect of it is evidence-based. We want to keep the patients NPO until they have a swallowing evaluation. That's the second time I've said that. So if you suspect that a person has a new focal deficit, please don't give them anything by mouth until a swallowing evaluation is done. We do them 7 days a week, and that should be done. I don't care how mad the patient gets, we really need to be aggressive about this so we don't have any silent aspiration, because it's one of the big problems with stroke. What is this? Patient presents at 5 hours. Am I going to give IV TPA? No. Patient has, again, one of these, plegic on the right, aphasic or mute. Eyes are forced deviation to the left. That's a hyperdense sign, very bad, big long clot. Even if the person was within the window for TPA, IV TPA, it would work less than 10% of the time because it's a very long clot. Hard to churn through that. But this person was 5 hours out, so not in the window for IV TPA, bad-looking clot, bad-looking patient. In fact, the CTA shows a loss of flow in the MCA, proximal MCA. This is the CT perfusion study. So on the left, what you're looking at is a core stroke. We're looking at these voxels looking at core stroke, and in this area we have really no core stroke showing up. The two sides are equivalent in terms of blood volume. However, when we go over here, we're looking at the time to peak perfusion, and there's a huge deficit, a very long latency of time to peak perfusion on the left side. This is a mismatch. So I told you about MRI diffusion-perfusion mismatch. Here is a CT perfusion study which gives us a huge mismatch. So what do I want to do with this patient? Lower their blood pressure and tuck them in? No, take them to vascular, don't I? So intra-arterial thrombolysis is one option where a neurointerventionalist can thread a microcatheter up to the level of the clot and just basically squirt TPA on the clot. So that gives you about a 6-hour window, and that's only based on clinical trials. It's not voodoo. You could do it at a later time if you had the studies. This was based before we had CTP, and before we used MR perfusion. So if you have a significant penumbra, then you could go ahead and do it outside of that window and be safe. Why don't we just not worry about the penumbra and go in and open up a vessel that's blocked? If the brain is dead, it will bleed acutely. So we need to know that we'll be safe in opening up the vessel and reperfusing that brain. And so here's an example of intra-arterial thrombolysis where you go in and you have a complete occlusion over here. I have no idea how to make the light come on, but you can see it. And so then as we are able to clear out clot, we get reperfusion of the middle cerebral artery. You can see these people on the table beginning to recover. So that's really exciting too. I love it when we send somebody down to vascular from the ER and then they come back waving at us and talking to us. It's a very good feeling. Doesn't always happen though, because these are very, very sick patients and their vessels are very sick. So we had to come up with something better than only a 6-hour window, because still patients don't come in time. A device that is FDA approved since 2005 to remove clots. They didn't go as far as to say for stroke treatment, but anyway, clot removal, is the MERCI corkscrew device. Have you heard of it? So right after it was the device was FDA approved, we used it here with a 26-year-old lady who woke up with left-sided weakness, went to Clark Memorial. They did not give TPA. She woke up with the symptoms, went to MRI because they said, gosh, what's going on with this 26-year-old who's healthy? MRI showed a brainstem stroke and a blocked basilar artery. 85 to 90% mortality if you do nothing with a basilar. So we brought her over, took her down, and used the MERCI, got the clot out. She's normal and she's fine today. That was, but your question is, why did a 26-year-old who's healthy have this? She had a spontaneous dissection of her vertebral. She didn't have any trauma to it, no chiropractic manipulation or anything. She had a spontaneous dissection of the vert, formed a clot, boom, went up, blocked the basilar artery. Really bad news. But she did very well. Somebody recognized that she needed to get somewhere where they could do something about it. MERCI. Engage the clot, pull it out. Sounds easy. There are a lot of problems. The patients come in and they're sick. The vessels are very sick and friable. You can break the vessel. They can bleed. Some of the clot can break off and go up as embolus. A lot of problems, but it was better than the alternative, which was nothing in some of these cases. This is a clot that we got out with the MERCI in 2007 from a 47-year-old lady who had full dose TPA. She came in with left neglect, left plegia, left facial droop, homonymous hemianopia, eyes deviated to the right. That was in her right MCA. TPA didn't touch it. An hour after TPA, she was the same. Took her to vascular, they pulled this out. It wasn't a big miracle. She went to rehab. She was in rehab for months. But when she came back to clinic in 6 months, she came in with a quad cane, but she walked in with a quad cane. I mean, that's a good thing. And that's a good outcome at 3 months. And so those are good things. Penumbra is a set of tools to aspirate. It just sucks the clot out. Easier on the vessel wall, but not so far. We don't think that it's that much better than the MERCI, but certainly better than IV TPA in recanalization rates. The best new kid on the block and the easiest, and you'll find the interventional neurologists around the world really enjoying the Stent retrieval devices because you catch more clot, there's less embolus, it's easier on the vessel walls. So the Trevo and the Solitaire are the names, and they are also in investigations now. We're looking at, yeah, we can open the vessels. We can open them very well, But what we're looking at with the clinical trials is what's the functional outcome of these patients at 3 months and 6 months and longer. So those are the big things that are happening today as we speak. There are other things that we do with these patients. We do MRI, MRAs. We do EEGs on patients especially who have mental status changes and cortical strokes. 2D if you can't do a TEE. 4-vessel angios are still being done to get a better view. Sometimes MRAs overcall a stenosis. Transcranial Dopplers if you can't do MR or CTAs. Carotid ultrasound occasionally. It's not in the guidelines as an initial study, but we do use them to look at velocities or a secondary non-invasive study. Lower extremity Dopplers if you suspect a clot or anybody that has a PFO or a clotting history. What about if the person is not a TPA or intervention case? So, of course, we do our stroke scales, we look at our vessel imaging, we get our labs. We come up with blood pressure targets for individuals based on their vessels and the entire picture. The guidelines still say don't treat blood pressure in an ischemic stroke until that blood pressure is greater than 220 over 120. And so that really is scary, but we're trying to protect the penumbra. If you've got an occluded vessel and you still have a penumbra, the penumbra is there because of collateral blood flow, so high pressures. But in this house, you'll find all 4 of the attendings, 10 stroke attendings, tend to go with the 180s rather than 220s. But again, the guidelines are out there based on the fact that we don't really have defined numbers yet. And we do have data that shows that we protect the penumbra when we keep the pressure up. If you're going to bring the pressure down acutely when you're taking care of the patient in the hyperacute stage on the first day, you want to use IV drips that can control so you can give a target blood pressure based on the vessels and the whole scenario. Individualized care is the key. Of course, treat blood pressure, blood sugars, fevers, infections aggressively. All 3 of these will cause the core stroke to enlarge and lose the penumbra and cause more bleeding. Just to let you know that there's a 3-fold increased risk for higher mortality in patients with hyperglycemia. If they're non-diabetic, and the diabetics, it's double the risk. The reason why we want to treat hyperglycemia in the acute stage, especially with TPA cases, is because there's more hemorrhagic conversion in TPA cases. If the sugars are high, outcomes are worse. Here's our protocol. It's just what I said, all of the things that I tried to go through with you. But I also want to tell you that there are other things that we need to do. I mean, it is not cut and dry, and it is not a cookbook, and we are not good enough. And so it's very important that we improve our interventions so that we can capture more patients. We need to do a better job. We need to have better thrombolytics. There's one called desmodoplase. We used to call it bat spit. Desmodoplase is 12,000 times more potent than TPA. So it's being studied. We were in 2 of the pivotal trials. There's a 3rd one going on that we're not involved in. We need to shorten the time window to treatment. EMS needs to be more involved in the early stage. We're involved in a stem cell study after stroke, looking at are we going to be able to salvage the surrounding tissue. Need novel medications. We need to think outside of the box. We need to do better with rehab. Rehab is critical. New circuits form in the brain because of rehab. We need to prove that. I mean, I've seen it. I was a speech pathologist before I was a neurologist working with stroke patients, and rehab makes a difference. It gets people speaking that never would have talked if they didn't get the rehab. We know it. It's been proven, but we need better protocols. We need to expand our reach, reduce risk factors. We all are in it together to reduce the risk factors aggressively. And we need to partner. Break down geopolitical boundaries and partner to do a better job with caring for these patients. We have robots, but in the Kentucky One Health, we're going to have different. We're not going to have just the robots, but we're going to have other telemedicine equipment. We're going to have it in the ERs. You're going to be able to see patients by telemedicine in ERs around the region, but also we'll have outpatient telemedicine capabilities throughout the region. Here's Europe. Europe is a little ahead of us with their EMS. We're looking at this. A colleague of mine just started a protocol at UCLA, stroke program, great stroke program in this country. I just read about it this week. I knew he had gotten funding for this. This is an ambulance, and there's a CAT scanner in the ambulance. So there you go. So it's come across the pond, so to speak, and so Jeff Saver at UCLA is going to be doing it, and a friend of mine at Austin, Texas, just got funding. So we'll see what happens with this. Hopefully it'll make a difference, because patients do have long rides in to stroke centers, and not just here, but in other states. I mean, there are wide expanses between facilities. I'm so excited. I have a little time. I talk so fast, so I'm going to talk about hemorrhage. Can you hang in there for just a few more minutes? You will get patients that change on you at the bedside. I mean, you'll see them, and then the nurse will call you 15 minutes later, and there's a big change, and they look like they're having a stroke. But you're not going to know whether it's ischemic or hemorrhagic. I don't know if it's ischemic or hemorrhagic by doing a neurological exam. So you have to go down the pathway, and in our protocols, look at that. Very common is hypertensive hemorrhage. The most common sites for hypertensive hemorrhage are these. Basal ganglia, very common, thalamus, pons, cerebellum. If they have a bleed in the lobe, we're starting to think about other things than a hypertensive hemorrhage. If they come in with a bleed in a lobar hemorrhage and their blood pressure is very high, I don't just automatically knee-jerk say hypertensive hemorrhage. Even if it's basal ganglia, I don't just knee-jerk say it, even if their blood pressure is very high, because we lose autoregulation in the brain with stroke, whether it's hemorrhage or ischemia. So blood pressure can be anywhere after the stroke. So I don't want to assume anything. A person could bleed into a tumor in the subcortical areas. But lobar hemorrhage, older person, lobar hemorrhage, I'm thinking, are they demented? Could be amyloid angiopathy. Or lobar hemorrhage, person with migraines, maybe it's some type of a vasculitis. There are other conditions, so we have to think about some of the other causes. Size matters. That's why I have the ping pong ball and the golf ball. They don't look like they're that much different, but that's the difference between independence and dependence, and that's what matters to us. So in the smaller hemorrhages, less than 30 cc's, typically people will get better over time, and they'll end up with just kind of a slit left over in their brain where that hemorrhage was. But the damage from a hemorrhage is collateral damage, right? It's a space-occupying lesion, so that's what causes damage. So their initial, if they come in obtunded, that's a prediction of bad outcome. Initial hematoma size matters. Age, whether they have intraventricular hemorrhage matters for sure. And then a point about withdrawing care. You'll read it in your literature. We don't want to just, oh my gosh, they have a hemorrhage, we're going to withdraw care in the first day. So one of the big points that is being put out by the Academy of Neurology, the American Academy of Neurology, is please carefully evaluate this person and look at the possibility of functional outcome. Don't just knee-jerk withdraw care because there's a hemorrhage. And I'll tell you a little bit more about that. So in this hospital, Comprehensive Stroke Center, we are checking an ICH score, which involves the size of the hemorrhage. We also look on our own for function scores. There's an app called the Neuro Toolkit. It has many different things in it. And one is, all you have to do, you can get the ICH scores and you can get the ICH volumes, the intracerebral hemorrhage volumes, by just plugging in the numbers. And it gives you the score. So that's nice instead of having to calculate it yourself. But you're looking at, of course, greatest span in terms of the width and length, as well as the depth of that hemorrhage. And then the FUNC score is really a prediction of independence at 90 days. And that's useful. And so what it does is it looks at, a high score is good, so it looks at the size of the hemorrhage, the age of the patient, the location, low bar being a shallow and deep, being like a basal gangliar hemorrhage, and then also the GCS when they come in. And so then you can predict a person's 90-day independence. This is very important and very helpful. How do we manage these people? Now, we were involved in a study looking at hematoma expansion. There's a huge risk in the early hours after a hemorrhagic stroke for hematoma expansion. Blood pressure is one of the factors, but also anticoagulation is another. The factor 7A studies do not recommend, the negative outcome of the second study really gave us the result that says do not use factor 7A in just a typical ICH. But for a warfarin-related patient, warfarin-related, then there is a trend toward improvement. And we have a protocol in place in this house where we can put into place factor 7A for a warfarin-related intracerebral hemorrhage. And we also use some other techniques, but prothrombin complex concentrates would be used with the neuro anticoagulants. And we're working on a protocol here. Several groups have gotten together and we're coming up with our protocol for those because we're having patients come in on the newer anticoagulants with bleeds. So not as many as we would have expected, but still we see it and we want to come up with a plan. And factor 7A is not recommended for those. What about blood pressure? We really don't know. Isn't that pitiful? But the guidelines say keep the systolic blood pressure under 160 in bleeds. We really even push it a little further, but we are involved in an NIH trial looking at what blood pressure range is really going to be the best for preventing hematoma expansion and poor outcomes in these patients. Here's a special case, and that's a cerebellar hemorrhage. Don't forget when you do a neuro exam to check finger to nose and heel to shin. So everybody needs to check that if there's a change in your patient. But anyway, so a hemorrhage in the cerebellum is something that if it expands, the person can herniate downward and die immediately. That's a neurosurgery consult if a person has a hemorrhage. They typically will do surgery to decompress it if it's greater than 3 centimeters in diameter, but they need to be on board from the beginning, and we want our neurosurgery colleagues on board with us. But typically they'll go with medical therapy if it's less than 1 centimeter. You always monitor for hydrocephalus and mental status changes. They shouldn't have sleepiness, and you certainly are behind the 8 ball if you have brainstem compression and a blown pupil. And then we have protocols and hemorrhagic stroke orders if you have a patient, and you're welcome to use the stroke orders. One point that I wanted to make about this is the STITCH trial. So this was a medical management versus surgery for bleeds. And the first trial was negative. It was stopped early. The medically treated patients did better than the surgically treated patients with intracerebral hemorrhage. Then they looked at these, and we do sub-analyses, and looked at those and found that, well, the shallow bleeds did better with surgery than the deep bleeds. The deep bleeds did much worse. So STITCH 2 is going on, and looking at shallow bleeds, medical management versus surgery. And so that'll be something that you can look for over time. We don't have any results yet. Perfect. Are there any questions? Yes, ma'am.
You mentioned that the post-TPA orders said no interventions like procedural interventions. Then I thought in the patient you were describing, you said that you did the neuro intervention after the TPA.
So, good point. So the question was, I'm assuming that you're saying, how definitive is that exclusion, or how definitive is that on the stroke orders that no, in fact, they say no sticks, and we're putting a catheter in the groin, right? So that is a relative feature. TPA clears very quickly, but we have not seen problems right after, an hour after TPA, in going in with a microcatheter. And so, good point. We do blood draws, but that is a relative contraindication. Thank you for asking that. Well, we welcome you to rotate with us and to do, I'd like to, if anybody's interested in possibly a fellowship in stroke, maybe we should look at that possibility. I think that down the road for a comprehensive stroke center, you should have an internist on your team every single day. It will reduce length of stay, will improve the care of these patients, will improve their outcomes. And so that's something that I believe should be done. And that's why I'm so excited about you all having a fellowship, a vascular fellowship, so that you can be that stroke person in these stroke centers, but you'll also take it a step further and help these patients even more with their comorbidities. Thank you.